So first of all, I'm very thankful to Dr. Manoj Chawla, Dr. Purvi Chawla, and the whole organizing team of DRS. Thanks for inviting me, and thanks for giving me the opportunity of sharing the Mahakumbh experience with all of you. So this Mahakumbh experience is not only my experience; it is the experience of many of us, the members of RSSDA. Very interestingly, the slide that you see, and if any of you can recognize the previous speaker, there's a pointer. Huh? I'm sorry, I think. देखा? Okay, this one. So, this is our previous speaker. I'm very proud to share with all of you that we are together once again. So we have wonderful experiences together. We've been meeting, but one of the best experiences I'm sure Dr. Ketan would also remember throughout his life is the experience in the Mahakumbh. So this health awareness camp, or we called it diabetes awareness camp, Madhumeh Jagriti Shivir, was a wonderful experience. And the topic that Dr. Manoj Chawla had given to this is actually similar. Is sharing with you the experience and the findings and the outcomes of this community-based screening and risk assessment for diabetes, hypertension, and cardiovascular disease at Mahakumbh Prayagraj in 2025. So what is the background and the rationale? India has a very high NCD burden. We all know for that. The high prevalence of diabetes, hypertension, obesity. We have all seen the results of the final publication of ICMR in-depth study in 2023. So the impact of all this is that the NCDs contribute to 63% of all deaths in India, which is a staggering and humongous figure. What these religious gatherings do is that they give us an opportunity. They give us an opportunity to meet the people, the population, and it is a very unique opportunity to conduct public screening and health awareness camps. Purpose here was to leverage the Mahakumbh 2025 to assess NCD prevalence and promote health interventions. So we all know that it was a very unique event, the Mahakumbhs. Almost 65 crore people, half of the population of a country gathered at one place. This itself is a huge achievement and something unheard of, nothing to repeat. So it is an ideal setting for the large-scale screening and epidemiological data collection, because look at the in-depth study and other studies that we frequently talk about. It is very difficult to go over from house to house and examine patients and collect data. Here we had a great opportunity because people were coming there. So we just had to somehow move out amongst them or bring them to us, and we had this opportunity to screen and gather the data. So we know what is RSSDA. It is Asia's largest body of doctors, professional doctors treating and managing diabetes. It is only the second largest in the world after the American Diabetes Association, a body of professional doctors. Its focus is on research, training, advocacy, and technological adoption. And it partnered with Mahakumbh 25 to conduct NCD screening and awareness campaigns. So I'll show you some photographs, then we'll move over to the data so that you have an understanding what and how we did. And the scale of things that we did was, this is Dr. Anubha Srivastav. She's from Prayagraj. She's in the medical college. She was very helpful in the organization. And these are the stalls or the camps that where we conducted the screening and testing. We also did an exhibition. Probably we'll have in one of the photos. We put up these big posters where people could easily understand what they were told of. So we had a team of 20 technicians, nurses, and dietitians who were explaining to all those who had some problems, all those who had diabetes, hypertension, or obesity, the importance about diet, and giving them very short dietary advices and handing out flyers or advices on that. And Doctors were there, like I showed Dr. Mehta, and I was there all the time, and many other doctors from RSSDI who were visiting the Mahakumbh, they offered their services and examined patients free of cost. And we obviously didn't charge. This is on one of the days, the whole team which was there from morning till evening. Patients, different types of patients, urban, rural, people visited. Professor Anuj Maheshwari sir, he is the President Director of RSSDI. He played a very vital role in organization of this camp. He gave his full and unwavering support, because of which I would say this organization, this camp as such was possible. And this is the inauguration. He himself came, he was there the whole day, examined patients, and he inaugurated the camp. Here we see Dr. Vanshi Sabu sir, Dr. Ajay Tiwari, and Dr. Professor Anuj Maheshwari sir. And these are some more pictures of the camp. This is the exhibition. We put a live exhibition. We put up things which people should eat and which they should avoid. And we were explaining them. So people actually had a very good visual understanding of the diet and things which should be done, which should be avoided. And this is the huge gathering we used to have every day. We have examined, we have screened almost 1400 people per day. And this whole effort was a very coordinated effort. It was done in such a way that the team of 20 people could collect all their data, ask them each questions. There were 17 questions, there were 17 data points which were collected on all the patients. And there were almost 40,000 of them. So you can imagine the task that we had to perform. These again some pictures. So, what were the objectives of the study? It was to estimate the prevalence of diabetes, hypertension, and obesity, assess medication adherence during the religious travel, identify demographic and behavioral risk factors. Medication adherence during the religious travel or religious occasions is very important, because from my experience in the Mahakumbh, what I understood was many people, when they went for the snans, they stopped taking medication right from their home, because they considered it unholy or not pious. Since they're going for the snan, they should stop taking all medications. Many were on vrat, even though they were walking 20 kilometers from station to the ghat, but they did not eat anything and they did not take any medication. Now the timings of the Mahakumbh, it was from January to February on the banks of Ganga. You can imagine the cold it is there, the weather. The weather used to be 4 degrees, 5 degrees in the morning when people would take bath in the cold waters without any clothes, not taking their medications. Many had started 2 days back, left all the medications. I practice in an urban area. I am a physician. I worked in hospitals. I hadn't seen alcohol abstinence scissors, but I saw them in the Mahakumbh. I was treating patients on the railway platform. I treated patients with alcohol abstinence scissors on train. Why? Because they stopped taking alcohol and they were used to it, and there has abstinence scissors. The same goes for the medications. People simply stopped taking their diabetes, hypertension medication because they were going for the snan. So we collected the data. A questionnaire was filled up. Every question was asked to every person. We did measurements of height, weight, blood pressure, random glucose, and pulse. And the data was collected in sheets by our volunteers, and it was later on digitized. So the ethical committee gave approval for this study. After that, we started. We have a lot more data, but the data that we are considering in our analysis is the one that we started after we got the approval, which was a little bit later than the start of the camp. So we have some very interesting results. Gender of the participants: 33.4% females and 66.6% males. And in age groups, we see Majority of them were in the age group of 40 to 49 and 50 to 59. So I think majority of the individuals that we screened were between 40 to 70. This forms the major chunk. Urban rural divide, majority of them 60% were rural and 30%, 36% were urban. And in BMI categories, so as you can see, majorly rural population, but the BMI is moving towards overweight and obesity. So this is a very good reflection of what is happening in our country. We talk about obesity, we talk about excess weight, but we talking usually in the urban centers, in the cities, in the metros. But see, this is what we have. Majority of the rural population here we see is overweight and obese with class 1 obesity. NCD prevalence. Diabetes 25.5% prevalence, hypertension 16.1%, CVD 5.2%, and any condition of these 29.9%. So now we'll have some diabetes specific findings that we had. This is the age. Now these are comparisons between people with diabetes and without diabetes. The mean age was 53% of those with diabetes and 47 without diabetes. And BMI almost similar. And in those who forgot medication, patients who had diabetes were more likely to forget medications than those who did not have diabetes. Alcohol use was more in patients with diabetes than those without diabetes. Tobacco use was similarly more in individuals with diabetes as compared to those without diabetes, because these were things we were recording, asking people, and they were responding. Hypertension was also significantly more. Almost half of the patients with diabetes had hypertension and very few without diabetes had hypertension. CVD 12.9%, almost 13% with diabetes, whereas only 2.6% with diabetes. So these are self-reported. So what people have reported from what the questions were framed previously by the ethics committee, and they were put up to the patients in their simple language in Hindi, and they answered. And from there we have these figures. And now a little bit about the random plasma glucose, the finger stick glucose measurement that we had. This is a very interesting fact that 8.8% of those who had reported not having diabetes were found to be having hyperglycemia. So most probably these are people who did not know that they have diabetes, but they actually had diabetes.
So Rajesh, you need to sum up.
Okay, so we've talked about diabetes. In conclusion, the high NCD burden, nearly 1 in 3 pilgrims had diabetes, hypertension, or CVD, highlighting the silent epidemic of chronic diseases, and demographic differences, higher prevalence in older age groups and among rural participants, emphasizing the shifting disease burden to non-urban populations, risk behaviors, significantly higher rates of alcohol and tobacco use in those with diabetes or hypertension. Medication adherence, large proportion of participants miss medications during the travel, 28.6 for diabetes to 43.6 for hypertension, creating a risk for acute complications. And mass gathering feasibility, the Mahakumbh demonstrated that large scale, rapid, community-based NCD screening is both practical and impactful. So what are the public health implications? Mass gatherings as health platforms. This is something new which we could utilize. Events like Kumbh can act as mega health camps, offering outreach to populations that are otherwise difficult to engage. As we've seen in the numbers in the previous slides, majority of individuals who were screened and treated were actually from rural areas. It may be very difficult to reach out individually to all of them, but here all of them are gathered and we could so well engage them and offer them some help. Policy value. Such initiatives provide real-world prevalence data for policymakers, supplementing national surveys like National Family Health Survey and the ICMR INDIAB study. Health system preparedness, screening at religious gatherings builds capacity for emergency management, triage, and referral systems. Behavioral health identifies urgent need for medication adherence support during travel and ongoing long pilgrimages. And equity in healthcare brings healthcare to rural, underserved populations who form the majority of attendees. One more thing I would like to mention here is that not only we did this screening, we did the counseling and treatment, but we also gave them medication. So this also, I think, was very important event that happened, that medications were distributed to those patients. We actually anticipated that a lot of the patients may be forgetting insulin, may be forgetting their medications because of different reasons. So we went prepared, but we understood that our preparedness was not sufficient, not enough. So we kept on building stocks, and every day, sometimes hundreds or maybe thousands of patients were being distributed free medication as long as they lived there. So, recommendations,
you need to
medication
be-
adherence provide
Rajesh,
still organizers.
Need to.
Okay. So, this is the last slide, the conclusion. I think we've discussed a lot about it. So, thank you. Thank you.